Thanks, John, for the invitation. My challenge is to tell you a little bit about Parkinsonism. And first of all, maybe to just, what do we mean when we say Parkinsonism? Parkinsonism is a clinical term. It describes patients that have slowing of movement. And that's the sine qua non for a Parkinsonian disorder. They have to have slowing, but they often have tremor or rigidity as well. When we talk about Parkinson's disease, it's one of those Parkinsonian disorders. And it has clinically pretty well-defined criteria. They usually respond to dopamine replacement therapy. It's often an asymmetrical disorder, and the overwhelming majority of the patients have synuclein or Lewy body pathology. Another term that we use is dementia with Lewy bodies. And this is a really bad clinical term because it refers to a pathologic structure. But the way we use DLB is to refer to an individual that has progressive cognitive impairment with a constellation of other clinical features such as visual hallucinations, fluctuations, rigidity. They may or may not have Parkinsonism. It's not a required clinical criteria for DLB. If we talk about pathologic terms, we talk about Lewy body disease, or a term that Jim Leveren's coined, Lewy-related pathology, and that's what I'm going to try to use when I'm referring to the pathology, to distinguish pathologic from clinical. And we look at the distribution of the Lewy-related pathology, and there are various staging schemes that have been developed for this, but it's also increasingly recognized that Lewy bodies can be found, for example, in the setting of Alzheimer's disease, where it has a very peculiar distribution. It affects the limbic parts of the brain, the amygdala. And that we can also find Lewy-related pathology in olfactory bulb. The other thing that's known is that about 10% of people over age 65 have Lewy-related pathology, and it's not associated with any clinical features, and we call this incidental or coincidental Lewy body disease. Here's a graphic illustration of the Parkinsonian syndrome. I would just draw your attention to that of all these various features, the most important is slowing. Although there are a variety of things that can cause slowing, if you don't have slowing, you don't have Parkinson's disease. And this, I guess, is where we came up with the term of substantia blanca. So in the midbrain of, there's a group of neuromelanin-containing neurons in a normal individual. In the substantia nigra, these are dopamine-producing neurons. In the locus coeruleus and the pons, they're noradrenergic neurons. In Parkinson's, these neurons are lost, and the pigment is lost as well, so that you don't have the neuromelanin pigment. This corresponds to decreased innervation of the striatum, and you can measure a striatal dopamine innervation by using a variety of methods, but a method that's very useful in postmortem tissue is tyrosine hydroxylase immunohistochemistry, or immunofluorescence. And TH is the rate-limiting enzyme of dopamine synthesis, and it can be used as a marker. And you can see the decreased number of the fine dopaminergic neurites in the putamen in a Parkinson patient compared to a control. Interestingly enough, when we looked at a series of normal individuals, we also found that there seemed to be an age-related decline in dopaminergic innervation. And I think it's, if we think about aging, one of the hallmarks of aging, sort of the usual aging that John was talking about, is slowing. Many people, in fact, if you think about professional athletes, they become old when they're in their 30s and 40s because they're slower. And this demonstrates that, in fact, as part of aging, some of that slowing might be related to decreased dopaminergic innervation of the striatum. If we think about the Parkinsonian disorders, the most common disorder is the synucleinopathies. The Lewy body is composed of synuclein, and these include Parkinson's, I've mentioned, dementia with Lewy bodies, and a much less common disorder, multiple system atrophy. The tauopathies, and John's already introduced this concept, and I would just illustrate two of these and go quickly over CTE because John's already giving a good introduction to that. The most common of the Parkinsonian tauopathies is progressive supranuclear palsy. And then there are a variety of other disorders that are associated with Parkinsonism in which they don't have tau, they don't have synuclein, and some of them have just non-specific neuronal loss. Some of them, an interesting disorder that's quite rare, but I've actually had the opportunity of seeing the brain of a patient from Sinai who was followed by a pulmonologist here at Mount Sinai. And this patient presented with central hypoventilation and came to autopsy. And the autopsy was actually done at Columbia. And when I reviewed the slides in consultation from the pathologist at Columbia, we discovered that this patient had TDP-43 pathology. And that's the hallmark of this disorder. And it's not a very well-recognized disorder because, in fact, patients may present with Parkinson's. They may die in their sleep with hypoventilation, or they may die because they commit suicide because of depression. But this is a non-tau, a non-synuclein Parkinsonian disorder. It's hereditary. And in fact, if we think about the synucleinopathies, we can divide them into those where they have a strong genetic component and those in which they're sporadic. Mutations in the synuclein gene itself can cause Parkinson's. It's often a very atypical type of disorder. It presents at a young age. It may have a variety of non-motor manifestations such as autonomic dysfunction and increased frequency of cognitive impairment. There are about 5 or 6 coding region mutations in the synuclein gene, and the synuclein gene can also be duplicated or triplicated. The most common of the genes that leads to typical late-onset Parkinson's is a mutation in leucine-rich repeat kinase 2. And the pathology in leucine-rich repeat kinase 2 patients is heterogeneous. The majority of them do have Lewy-related pathology, but there are some individuals that have tau pathology and actually some that have TDP-43 pathology. And then these are the most, when we typically think about sporadic Parkinson's, we don't have a good genetic basis for it. And of these, certainly there's some increasing studies of identifying genetic risk factors for Parkinson's and DLB. There's much less evidence of a genetic component for multiple system atrophy. The synuclein gene is on chromosome 4, and it actually undergoes alternative splicing. The alternative splice forms are of uncertain relevance. There is some evidence from investigators in Spain that they may be more common in patients with Lewy body dementia. The protein that's encoded has 3 major domains, and exhaustive work by the group at Penn, Virginia Lee's lab, has shown that there's a region in the central part of the molecule that's hydrophobic that leads to self-self interaction, and they've identified a small region within this hydrophobic domain that's critical for the synuclein molecules to self-aggregate and to form structures that eventually lead to Lewy bodies. The protein undergoes some post-translational modification, and the one post-translational modification that's of most relevance in terms of developing a specific biomarker for the disease is phosphorylation. And phosphorylation at 129 generates a very specific marker for pathologic synuclein, and it has been used in developing CSF assays for Parkinson's. The Lewy body is an eosinophilic hyaline inclusion in neurons. It was originally described in neurons that have a neuromelanin pigment. There's debate whether the Lewy body is an adaptive response or if it's a toxic lesion. What we do know is that neurons that are susceptible to Lewy body pathology do die, and in fact, sometimes we can see macrophages phagocytosing the neuromelanin with an extracellular Lewy body. So even though it may be adaptive, eventually it's a failed adaptation. The other thing that we're learning is that Lewy bodies have much more extensive distribution in the brain, and they're more difficult to detect in cortical areas or in certain limbic areas like the amygdala. And we refer to these as cortical-type Lewy bodies. But despite their differences in morphology, they all can be detected with synuclein immunohistochemistry. So here's the so-called brainstem or classical-type Lewy body, and these are the cortical-type Lewy bodies. The The difference reflects perhaps the length of time that the inclusion has been present in the neuron, other intrinsic differences in those neuronal populations. The other thing that's very important to note is that when we think about this, the burden of pathology in synucleinopathies, the majority of the abnormal synuclein is not within the neuronal pericardia. It's actually in cell processes. There's far more abnormal synuclein in cell processes than in the cell bodies. Just as John showed you the staging scheme that Heiko and Eva Brock developed for Alzheimer's disease neurofibrillary tangles, Heiko and his colleagues also developed a staging scheme for synuclein pathology that occurs in Parkinson's disease, where the initial pathology occurs in nuclei in the medulla that are part of the parasympathetic nervous system that actually project to and from the periphery of the nervous system, with the second stage involving tegmentum of the pons, in particular graft nuclei and the locus coeruleus. The third stage is characterized by involvement of the substantia nigra in the midbrain, early involvement of medial temporal lobe, fourth, more extensive involvement, including the amygdala, and then the fifth and sixth stages are associated with synuclein pathology spreading to higher order cortical areas. And that's led to this hypothesis that there's a prion-like spread of the pathology from one region of the brain to the other. The other thing that's worth pointing out here, as I put in red, is that the area that's most vulnerable in terms of association with a clinical syndrome is midbrain dopaminergic deficiency. And what that says is by the time that somebody has Parkinson's, it means they've had the disease for some time prior to that. And it also suggests that there may be other clinical manifestations of that pre-motor phase of the disease. So this is what we talk about. We talk about the clinical motor syndrome with Parkinson's. But in fact, they have a number of other manifestations that may reflect involvement of brainstem areas or the olfactory bulb. And that in the late stages, with the spread of the pathology to the cortex, that accounts for some of the cognitive impairment that occurs. And this led Bill Langston, who runs the Parkinson Disease Institute in California, to suggest that the nigral degeneration, the motor aspects of Parkinson, just the tip of the iceberg, that in fact this is a disorder that has many other faces. Just a little bit about hyposmia. This may be a useful marker for preclinical Parkinson's disease. It can be detected with specific tests. At the University of Pennsylvania, they've developed a scratch and sniff test. It's being used widely now by the Michael J. Fox Foundation to look at prodromal Parkinson's disease. They're looking at patients or individuals that have olfactory dysfunction and then following them to see their risk for going on to develop Parkinson's disease. And Tom mentioned that the autonomic nervous system is also affected, and this has actually led to the hypothesis that in fact maybe the initial portal for whatever the pathologic form of synuclein is actually might be in the periphery. And in fact, there are many organs in the periphery that have abnormal synuclein in the setting of Parkinson's disease, and there's a great deal of research to try to determine if that pathology actually precedes the Parkinson's disease. Eventually, patients have not only the abnormal synuclein, but they have neuronal loss that accompanies that. And there are ways in some parts of the world to actually measure this sympathetic denervation that occurs in the heart with the MIBG tracer with this scintigraphy. This tool is not yet available in the United States, but it shows that in Parkinson patients, there's loss of dopaminergic innervation of the heart. And if you look at this in normal individuals, if you look at the epicardial nerve fibers, you can see Th-positive fibers. They're lost in Parkinson's. And this is associated with progressive increase in synuclein. And this is from studies that we did in our lab that showed that there is decreasing Th as you go from normals to Parkinson's with those incidental Lewy body, the neurologically normal individuals that have Lewy bodies, somewhere in between. and this correlates with the Brock-PD stage and with the increasing amounts of synuclein. The person that has done the most work on this, the cardiac involvement, is Arimo in Japan, and he had he has the only study that I know of where he's correlated cardiac sympathetic pathology with stellate ganglia. The stellate ganglia is the paravertebral sympathetic ganglia that innervates the heart. And he, in the same individuals, looked at synuclein and TH pathology in the heart and the stellate ganglia, and he came to the conclusion that the initial pathology is actually in the heart, and that only later do you see the pathology in the stellate ganglia. And this suggested that the pathology might be a dying back process, or that at least the distal parts of the neurons are more vulnerable than the more proximal parts. Several studies that have given this idea that there's peripheral involvement, it raises the possibility that there might be ways to diagnose or to biopsy patients from the periphery to come up with a differential diagnosis of Parkinsonian disorders. And a lot of work on this is being done by Tom Beach and his colleagues in Sun Health in Arizona. And they've actually shown, and several groups have now shown, that you can detect abnormal synuclein aggregates in the nerve fibers in the salivary gland. They're targeting the submandibular gland. And they've investigated this both at autopsy, and they've now moved on to clinical trials where they're doing needle biopsies of the submandibular gland to see if they can detect the abnormal synuclein in the nerve fibers. So this would be particularly useful if this were a more aggressive or malignant disease. I think it's a bit extreme at this point, but it nevertheless would help differential diagnosis. Probably less invasive is a skin biopsy, and there's quite a bit of discrepancy in the literature of how well you can detect abnormal synuclein in skin biopsies. In an autopsy study from Japan, it's as high as 1 in 4 patients will have abnormal synuclein in the nerve fibers of either the blood vessels or the adnexa. When Tom Beach did it in his autopsy series, he was not able to find the same frequency. So more work needs to be done on the possible use of skin biopsies in the differential diagnosis of Parkinsonian disorders. Now, the late stage of this disease process involves widespread parts of the cortex. This gives rise to what we call Lewy-related cognitive disorders. One of these manifestations is cognitive impairment that occurs in patients with long-standing Parkinson's disease. So typically, Parkinson patients don't have significant cognitive impairment. They may have slowing of mental processes, but they don't really have dementia. But eventually, if the disease goes long enough, they will actually develop dementia that leads to impairment in their functional abilities independent of their motor functional deficits. The other form of this Lewy-related cognitive disorder is dementia with Lewy bodies. And I mentioned that these are patients that have Lewy body pathology. It's often widespread, and they have dementia from the very beginning. In fact, that's the defining clinical feature of the disorder, that they have progressive cognitive impairment. They usually have visual hallucinations, fluctuations in level of alertness. And a very common clinical manifestation is REM sleep behavior disorder. This is normally during dream sleep or rapid eye movement sleep, you're atonic. Your muscles are basically paralyzed. What happens in patients with Lewy body and Lewy-related disorders especially, they'll act out their dreams. So during REM sleep, when you should be paralyzed, you're actually moving. And this can be documented by simple questionnaires, by asking the bed partners, and it can be detected with a single question. There's a single questionnaire: does the patient act out his dreams? It also can be confirmed with more sophisticated tests like polysomnography. This just summarizes some of the clinical features. Just point out that they may or may not have Parkinsonism. Certainly the majority of patients with Lewy body dementia do have Parkinsonism. And that the distinction between Parkinson's disease, dementia, and dementia with Lewy bodies is primarily the course of the disease. Did the patient have Parkinson's and then develop dementia, or did the patient have dementia and may or may not have had Parkinson's? And for research purposes, we use the 1-year rule. Now, so the pathology in DLB, certainly a-Synuclein they have to have Lewy bodies. And they're usually numerous, they're usually widespread, and in Brock's scheme, they involve stages 5 and 6 when the cortex is widely affected. But the reason we use the term Lewy-related pathology is it's not just the synuclein inclusions in the cell bodies, it's also the synuclein in the cell processes, or the Lewy neurites. The thing that makes this whole area complicated is the fact that the majority of the people that get Lewy body dementia are old. And because they're old, they have increased risk for Alzheimer-related pathology. And in fact, the majority of the patients have some degree of Alzheimer pathology. There's only a small minority, maybe 10% or even less, that have what we would consider pure Lewy body disease, in which they have widespread cortical Lewy bodies but no Alzheimer pathology. The majority have extensive amyloid deposition, but low Brock neurofibrillary tangle stage. But a subset, as many as a third or perhaps slightly more, have basically dual pathologies. They have both Alzheimer's and diffuse Lewy body disease. So I've mentioned these terms several times, and we've talked about Brock's scheme, very complicated. Kenji Kosaka in Yokohama was one of the first to actually recognize this as a distinct clinical pathologic entity. And in fact, the most widely used staging scheme for Lewy-related pathology is the staging scheme that Dr. Kosaka proposed, where the disease pathology is initially in brainstem predominant, brainstem with involvement of limbic areas, which he called transitional because it was transitional between brainstem predominant and diffuse neocortical. This is a system that's pretty readily available and understandable and reproducible from one pathologist to the next. But in terms of understanding Alzheimer pathology contribution to the clinical syndrome, we have to take into account the neurofibrillary pathology, and I think you might have had a similar slide, John, where this is Brock's staging scheme for neurofibrillary pathology, where the initial pathology involves the transentorhinal cortex, and then spreading to entorhinal hippocampus proper, and eventually to temporal lobe, multimodal association areas in the temporal lobe, and then the convexity cortical areas in the frontal, parietal, temporal areas. And the very last stage involves primary cortices, especially the primary visual cortex. Now, to diagnose pathologically dementia with Lewy bodies, you have to take into account not only the distribution and density of Lewy bodies, but also the amount of Alzheimer pathology. And as a pathologist, we like to make diagnoses that are clinically relevant. So if we just say it's diffuse Lewy body disease and it's Alzheimer's disease, Brock stage 6, that's not very helpful. But if we can append to that descriptive diagnosis a statement that says these are findings that are likely to have been associated with this DLB syndrome, then we're doing a little bit more of a service. And so this is the scheme that's been proposed in 2005 to generate this matrix of likelihood that the pathology would correspond to that DLB syndrome. And so the greater the Lewy body burden, Lewy-related pathology, the more widespread, the higher the likelihood, and the more severe the Alzheimer pathology, the lower the likelihood. So people with brainstem-only pathology, they don't typically have dementia. People with diffuse cortical Lewy bodies and minimal Alzheimer, very high proportion of them have Lewy body dementia syndrome. And this is actually from the Mayo Clinic prospective cohort, in which patients were given a diagnosis of DLB or AD, probable DLB or probable AD while they were alive, and then they came to autopsy. And you can see that the that 100% of the people in this bin actually had DLB as their clinical diagnosis. And so the high likelihood group actually works pretty well in terms of predicting what their clinical syndrome would be. And that virtually none of the individuals with brainstem have a dementia syndrome. So I think this works pretty well. And there's some, I guess this is the area where there's the most ambiguity. And it's because even if you have widespread Lewy body disease and you have concurrent severe Alzheimer pathology, the way to think of it is Alzheimer trumps, like love trumps hate. Alzheimer trumps Lewy body. So these are some of the features, looking at these the two groups of individuals, the clinically probable DLB, clinically probable AD. How do they differ? The most significant difference is the core clinical features that make up DLB, like visual hallucinations, Parkinsonism. How do they differ when it comes to pathology? The things that are most statistically significant are the presence of Lewy bodies that are abundant in the clinically DLB and really absent in the clinically probable AD. I just have one or two slides on multiple system atrophy. This is a really quite rare disorder, maybe 1/10 or even less as common as Parkinson's disease. It's typically a sporadic disorder. There are two major forms of it. There's a form that affects primarily the cerebellum. The patients present with a cerebellar ataxia. And then there's a form that presents with an atypical Parkinsonian disorder that's symmetrical and doesn't respond to therapy. So in terms of Parkinson's, this is what's also referred to as the striatonigral degeneration, where the putamen, where those dopaminergic neurons project, degenerates, as well as the substantia nigra. This really doesn't affect the caudate as much as the putamen, and there's a topographic distribution, so the areas that receive the most dopaminergic innervation are the areas that degenerate most. The pathology here is primarily characterized by synuclein within oligodendroglial cells. And so here, these are some of the glial cytoplasmic inclusions in oligos. Here's an EM of an oligo with a synuclein inclusion. A subset of patients also have inclusions in neurons, but they don't fit at all the same distribution of Lewy bodies. The places where we see these types of Lewy-like inclusions are in the putamen. We almost never see Lewy bodies in Lewy body disease in the putamen. They're in the pontine base, pontine nuclei, not an area affected in Lewy body disease, and they're in the inferior olive, another area that's not affected in Parkinson's. So it's a really different selective vulnerability. Actually, we were looking for incidental Lewy bodies in a cohort of normal individuals, and we actually discovered two patients in this almost 400 patients that actually had synuclein pathology. And so there is a prodrome for this disorder, but it's such a rare disorder that you have to look at huge numbers of cases to even find one or two. The other thing about MSA is a difficult diagnosis from the clinical perspective. The patients have Parkinsonism, they can have ataxia. The defining sort of sine qua non for a clinical diagnosis of MSA is autonomic dysfunction. And in fact, the disorder was originally described by two neurologists in Philadelphia, Shai and Dreger. So it's sometimes called Shai-Dreger syndrome. And the emphasis was on this idiopathic autonomic dysfunction. But in fact, if you look at people that are clinically diagnosed as MSA, they don't always have MSA. And this is from a series of over 130 patients with clinically diagnosed MSA. And you could see that there's There's a significant number of them that have Lewy-related pathology, either dementia with Lewy bodies or Parkinson's. And this is because, as I'll show you later, if you look at the clinical reasons for the misdiagnosis, it's almost always due to autonomic dysfunction. And we now know that in Parkinson's disease and in dementia with Lewy bodies, a significant number of those patients also have autonomic dysfunction. So a patient with Parkinsonism and autonomic dysfunction cannot automatically be assumed to have MSA. And interestingly enough, the few PSP patients that we had in our series had their misdiagnosis because they had ataxia. And we don't typically think of PSP as being an ataxic disorder. It's an atypical Parkinsonian disorder. But in fact, there's a small subset of patients with PSP that have ataxia, and it's referred to as PSPC. So I wanted to just briefly talk about PSP. And John mentioned this background information about the tau gene. It undergoes alternative splicing. The alternative splicing generates the three major classes of the tauopathies, those in which abnormal tau is composed mostly of 3-repeat tau, where there's 3 repeats in the microtubule binding domain, disorders in which there are predominantly 4-repeat tau, where you have 4 repeats in the microtubule binding domain. CTE is a 3+4. This is Alzheimer type tau, and PSP is a 4-repeat. So PSP is again about 1/10 as common as Parkinson's. It presents with unexplained falls. It's associated with an axial Parkinsonian syndrome rather than limb pathology. They have some very characteristic features. The disorder that leads to its clinical nomenclature is the impairment of vertical eye movements. They have a supranuclear gaze palsy. They have axial rigidity. They tend to fall. There are some characteristic imaging features. The midbrain undergoes severe atrophy, and it gives this what's referred to as the hummingbird sign. The diagnosis of PSP at autopsy can actually be made with macroscopic. You don't need a microscope for this diagnosis. If you have a brain that has this combination of features, severe loss of pigment in the substantia nigra in an atrophic midbrain with marked atrophy of the cerebellar outflow pathway, the superior cerebellar peduncle, with a small subthalamic nucleus, that's PSP. I've seen over 1,000 PSP cases. I've never seen anything else that would masquerade for PSP. So if you want to skip the microscopic studies, you can do that. But it's fun to do the microscopy, right? So, and in fact, this is a disorder where John mentioned the tau pathology is characteristically neuronal, but in fact, PSP is a disorder where it's a neuroglial tauopathy. So we see tau accumulating not only within neurons, but also in astrocytes and oligodendroglia. Interestingly enough, it's the neuronal pathology, as you might expect, that seems to be driving the degeneration. So if we look at 2 areas of the cortex where there's relatively more glial pathology, or an area where there's a mix but predominant neuronal pathology, such as the motor cortex and the subthalamic nucleus, and you use GFAP as your marker for neurodegeneration. If you look at the motor cortex, where there's plenty of glial pathology, there's almost no gliosis. In contrast, if you look at an area where you have neurofibrillary tangles and neuronal loss, these are the areas where you have gliosis. So we don't really understand the clinical significance of astrocytic tau pathology and oligodendroglial pathology. It's a hallmark of the disease, but what is it actually doing? Does it actually contribute in any meaningful way to the clinical syndrome? We don't really have good evidence that it does. This is the distribution of the pathology. It involves the putamen, the globus pallidus, the subthalamic nucleus, the substantia nigra, the tectum of the midbrain, the inferior olive, the outflow pathway of the cerebellum, including the dentate nucleus, and cortical involvement. If there's pathology, it's the motor cortex. So this is a system degeneration that affects the pyramidal and extrapyramidal motor systems. This outflow pathway is very characteristic. If you look at your midbrain sections at the level of the trigeminal nerve, you'll see striking atrophy of the superior cerebellar peduncle. And when we look, this is a series of normal individuals, and we measured this at this level. It's about 3 millimeters in diameter. And in PSP, it drops considerably to about half that. And it occurs early in the disease, but actually gets worse as the disease progresses. So it might be a biomarker. And John introduced chronic traumatic encephalopathy. I just want to give you a few slides on CTE. So the clinical syndrome is a frontal, executive, and behavioral disorder primarily, with emphasis on a number of behavioral features such as impulsivity, violence, aggression. Many patients do commit suicide. But I also want to emphasize that many patients with CTE also have Parkinson's and Parkinsonism. Anne has a seminal paper. If you want to learn more about CTE, I highly recommend this paper in Brain, where Anne developed a staging scheme like Brock did for Lewy bodies and tangles, in which the earliest pathology are these, what she calls epicenters of tauopathology at the depths of sulci in the convexity cortices. And then as the disease progresses, they become multifocal, and you start to see involvement of subcortical areas like the amygdala, the brainstem. And by the time you reach stage 3, there's involvement of medial temporal lobe structures. As John was pointing out, the medial temporal, this part pathology starts to overlap, except in part, you would not expect to see medial temporal with these foci that departs. And then finally, in the last stage, it's really widespread pathology. So John pointed out, this is a study that was done by a graduate student in my lab, Kevin Beniak, and he was interested in the frequency of CTE in our brain bank. And so he went through the medical records to try to identify patients that had been exposed to, that had been athletes in general. And he looked at all types of athletes, those that had been exposed to contact sports and those that were not. And then he did a matching, a 2-to-1 matching to get controls, and then looked at multiple cortical areas for CTE pathology. So we used the small sections to do our screening. We find typical pathology. And then for any case that we thought looked suspicious for CTE, we sent whole hemisphere sections to Anne McKee, and Anne did whole mount sections to allow you to more readily detect this multifocal nature of the tau pathology at the depths of sulci. And the bottom line is this, John mentioned that 30% of the patients that had exposure to contact sports, and it wasn't the non-contact sports. So we had people that were swimmers or runners or whatever, volleyball players. These were not, none of them had CTE pathology. And it was especially common, the most common of the contact sports associated with CTE pathology was in fact American football. And we didn't find it in any of the controls. None of the women, none of the men that were matched for demographic features and other types of exposures, except for this sports. So a little bit about what I've tried to tell you. Parkinsonism is a clinical syndrome. It has, there are a variety of different disorders that can produce Parkinsonian syndrome. Some of them are sporadic, some of them are familial. I touched briefly on some of the genetic basis of Parkinson's. Neuropathology, I think, it used to be that Parkinson's was simple. It was Lewy bodies. Now we know it's not just Lewy bodies. It's maybe even TDP-43 pathology, which is a word we haven't heard too much about today. But there may be forms of Parkinson's that are actually TDP-43 proteinopathies, Perry syndrome being the most obvious. And the other thing is, when we think about the role of pathologists and our contribution to nosology and classification of disorders, I think that we can really try to make a contribution to sorting out some of the mess, especially if we use molecular methods to understand the underlying molecular abnormalities that are part of the degenerative disorders. And the other thing to think that, and I didn't touch on this too much at all, but all neurodegenerative diseases are multifactorial. They include both environmental and genetic factors. We're making headway on the genetic factors. We have much work to do to try to identify genetic factors that are risky for Parkinsonian disorders, or really for all neurodegenerative disorders. And CTE is the one example where we know more about the environmental factor that gives rise to this disorder than we do the genetics. And my last slide, just to acknowledge some of the individuals that have contributed from my lab, our funding from the NIA, NINDS, and generous donations from Man-Gurion Foundation to support our Lewy body dementia program.